Epistemology, a big word. So what is it exactly? It's a branch of philosophy that tells us how we know what we know. And the way in which a human being gets to acquire knowledge, gets to know, is by three processes. An infant gets to know by way of sensation, and once the infant grows out, then we acquire knowledge either by perception or by conception. So, perception is, say, let's take an example of perception. There is this doctor several hundred years back who sees that patients who have diabetes are generally very obese. And another doctor, or the same one, sees that patients who lose a lot of weight, they also have their blood glucose levels normalized. So this is perception. Someone like Walter Porres put these perceptions together and said, okay, so what if we actually get people to lose weight big time so that we can get their blood sugars normalized? So bariatric surgery, metabolic surgery came in through such a conception. So how do we know? We see, we hear, we feel, and we make conceptions. So how do you test your conception? Because ultimately what we are doing is we are trying to acquire knowledge. So we try to prove our concept, our hypothesis, or rather we try to disprove it, the null hypothesis. So once that is done, then we arrive closer to the truth, or what we say is science is actually a search for the truth. So is evidence truth? No, evidence is not truth. Mathematics is truth, because 1 plus 1 is equal to 2 and has always been. People didn't come to different numbers at different times in history and then finally came to a consensus saying that, oh, 1 plus 1 is 2. So it's us who keep saying that today's evidence is tomorrow's myth. So evidence keeps changing, mathematics doesn't. So what we are essentially trying to do is we are trying to find the truth. So we're using evidence, which is an interpretation of the truth. So how do we improve the evidence? Now, we make a more systematic search for the truth. So over the years, scientists have come to the conclusion that the best way to do it is to have high-level evidence like an RCT, and you eliminate bias and get a better quality of evidence. But the RCT has its own inherent problems, so we all know that. So results may be inconsistent, the evidence may be indirect, and there may be bias in reporting. So let's look at an RCT which was published from Iran in the comparing the mini-gastric bypass and the gastric plication. So the study design was 20 patients in each arm, block randomization, and comparative results at 1 year. And the conclusion was, in short, that the plication was even better than the mini-gastric bypass because it was faster and there was a lower risk of iron deficiency, etc. Now, in real life, in countries where the mini-gastric bypass is done routinely, this is proven to be false on every given day. So we need good evidence, and the RCT may not necessarily be the only example of that kind of evidence. So good evidence has to be replicable, and it should eliminate bias, there should be no data fraud, and it should be uninfluenced by companies which are participating in the trial, and compare the same kind of variables. But we probably know all of that. Let's have an example of the study limitations when we're talking about study limitations in RCTs and other trials. Let's talk about the effect of the sleeve on GERD. So if we see the study limitation, some of the patients may be fully investigated and some have only the endoscopy, some have only the manometry and endoscopy, some have a barium meal and the endoscopy. Nobody has done a pH study or a manometric study. The results may be inconsistent, and if you check the literature, the results in terms of GERD resolution after sleep are pretty much inconsistent. So this is again a very important criteria for having good evidence, that you must have replicable results. Now, indirectness of evidence, someone may actually do a full scoring for a patient to assess the reflux, and someone may just ask the patient, have you taken antacids, and the patient says no. That's taken as evidence of resolution of reflux. And reporting bias, that's a very, very dangerous inconsistency which can creep in. Say the surgeon eliminates those cases he has converted to a Roux-en-Y bypass. So if that goes out of the trial, there's no conversion for reflux, so the numbers change. So there are two basic approaches now to patient care. How does all this research impact our practice? So we could either go by the rules, rule-based or science-based medicine, and the other way is to acknowledge that medicine is an art. So the surgeon's responsibility is to acquire knowledge and use it responsibly or appropriately. We are not pitching art against medicine. So there's a whole paradigm shift in learning. So the learning is not just rule-based learning, but what we call as narrative medicine. So narrative medicine allows the patient's complexities to be considered and understood, and specific details are taken into consideration when deciding what to do in a given situation. Whereas when you look at clinical medicine, can you just learn from papers, from studies? How are we learning today? Today, short of a long stint in an ivory tower where hundreds of different types of cases are seen regularly, you would be hard pressed to find that kind of experience. So an alternative is seen in a place like IBC, where surgeons from across the world pool in with their experience, with their knowledge, with their insights, and contribute to your specific patient problem. So if you see a specific case which you are having, someone's textbook answer may not really cut it. On the other hand, someone who has been in that exact situation may give you an insight, and you may not find an evidence base for it. For example, if you have, say, a patient with scleroderma and the patient needs a bariatric surgery, which is the best bariatric procedure? I don't think any evidence exists to say one or the other. Now, this kind of learning from IBC allows you to explore new procedures which have not been published. For example, we have one of our members who has presented on treating leaks with sponges, and it's very, very unique, and we don't know how good or bad it is, but if you've tested all the methods of managing a leak and you need an answer, this is an answer which wouldn't be available otherwise if we had just gone by what evidence there is in the literature. So narrative medicine is not rule-based, and it uses relevant knowledge. Epistemologically responsible medicine. Now, what do I mean by that? Medicine is not about just rules. Medical decisions are complex, they are case-based. The RCT doesn't tell you the entire truth, but we are not dissing evidence. The EBM is not invalid. Complex decisions should consider evidence, of course, but EBM is generic and clinical practice is specific. So epistemological responsibility means you're bridging evidence and your specific individual patient problem. And this is the new approach. We call this integrative learning, where you're learning from everybody. You're learning from the scientists, you're learning from your patients by the stories they tell you, and you're learning from your colleagues and peers in IBC. Thank you very much.